My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Today, we talk with Dr. John Biery, a family medicine-trained physician that currently teaches osteopathic manipulative medicine at the Alabama College of Osteopathic Medicine, after recently completing an Osteopathic Neuromusculoskeletal Medicine 3, or ONMM3 residency. In this episode, Dr. Biery discusses the various routes to ONMM3 residency, including his own unique path, which involved pharmacy school, the Navy, osteopathic medical school, a family medicine residency, a sports medicine fellowship, and finally, ONMM3 residency. Tune in to this episode to hear what one might expect during an Osteopathic Neuromusculoskeletal Medicine 3 residency, as well as how it has impacted Dr. Biery's career.
All right, John. So nice to have you here with us tonight. Thank you for joining us.
Thank you.
Okay, so tonight we have John Biery. John, am I saying your name right? John Biery?
Biery. It's like a German beer with a Y. That's how we describe it. So people can usually follow that one.
All right, John. So I want to start now. You recently finished an OMM fellowship. Is that right?
Correct. Yes. It's actually the Osteopathic Neuromusculoskeletal Medicine 3 year. And that 3 is to just signify that that's one of the pathways that ACGME has set up for the manipulative medicine residency programs. And it replaces the old +1 year that we used to talk about, where you could go and under the AOA program, that's how we designated it, but it's actually a residency program, not a fellowship in the classic sort of ACGME way of thinking about things. It's because there's only one board exam for osteopathic manipulative medicine. So all paths to get to that board exam are a residency path as opposed to a fellowship. Like I did a fellowship in sports medicine, it's been about 15 years ago. And that was a true ACGME fellowship. But this, because of the way that it's set up, it's a residency. And so I had to do all the stuff that residents do, recording in the ACGME system, all the patients that I saw, do all the ACGME trainings that they do for like interns. So I'm typing away on stuff that's, it was like I was an intern again. And it's like, oh my gosh. But yes, it was an awesome year, just an awesome year.
So John, just to be clear, so you're like, again, I want to go back. We're going to go through your whole history. We got a lot of things to talk about. But for this year, so you're a doctor already. You've already done a residency and you've done a fellowship, and now you're going back to do the year. Is that what most people do? And you mentioned that there are a few other pathways. Can you briefly tell us how you would become a neuromuscular medicine specialist?
So yeah, my path is a little bit unusual in that I went back to residency at age 50. So that's a bit of an oddity, and it was hard on the old man's bones to do that. But it was a lot of fun. But no, the Osteopathic Neuromusculoskeletal Medicine residency program, there are programs that you can join as a PGY1 right out of your medical school. You can go in, you can do your internship as part of that program, and then you matriculate to PGY2 and then PGY3, and then you graduate. You take the board exams, you become board certified in osteopathic neuromusculoskeletal medicine. Or you could do a transitional year internship, which is the equivalent of the old rotating internship that many osteopathic physicians would recognize, and or similar. It approximates, not exact, but it approximates that. And then you matriculate then as a PGY2 and do PGY2 and 3. And then there's this third option, which is the option I exercised. And that was where you complete another residency program of some sort. And then they take a look at all of the rotations you did during that primary residency and they pull out the musculoskeletal type of or manipulative medicine type of rotations that you did, and then they apply it to total musculoskeletal curriculum that you need to meet in order to be board eligible. And so that's what they did with me, because I had already done family medicine and I'd done sports medicine fellowship. I had plenty of musculoskeletal rotation, so it was very easy to meet all those requirements. I'd done neurology and physical. I hadn't done a physical medicine and rehab rotation, so that was one of the things that they asked me to do, even though I'd worked in an ortho office with physical medicine rehab doctors and stuff. So I had lots of experience from my practice. But yeah, those are the typical ways that you would go through. Like in my class, in my residency class, I had another gal who'd been out about 10 years out of family medicine, and she decided she wanted to do an additional year of OMM training. And then we had a fellow that was just right out of his family medicine residency, which I think is a more typical path that people take, is they know they want to get into academia, or that they want to have a practice that's heavily emphasizes osteopathic manipulative medicine. And so they just go ahead and add that year of training so that they can be board certified.
That's perfect, John. Thank you for explaining that. And now during that year, just so we can understand what that, now I think you're the perfect person to describe what's involved in the year, because other people, it sounds like maybe if they're doing that 3-year program, as you said, they're rotating in other specialties. So they're learning, they're learning to become a complete physician.
Correct.
Right. Which is the point of osteopathic medicine. And for you, you are already a complete physician. And now you're just spending that year focusing on what we used to call osteopathic manipulative therapy, and now is neuromuscular medicine. Right. And now, so can you tell me, is that outpatient? Is that inpatient? Are you seeing pediatrics? Are you seeing adults? And like, what type of pathologies are you seeing, and where are those patients coming from?
Right. Perfect. Great question. Yes, it's everything. In that year, and that's the interesting thing about the merger with the residency programs, is that, when they had to recalibrate, and they've always had, certain milestones or certain number of patients that you have to see in certain categories. And so we had to see patients, we had to see hospital consultations. We had a minimum number there. We had a minimum number of obstetrical patients that we saw, so pregnant women. We had to have a certain number of pediatric patients that we saw, and then a certain number of continuity patients. So those were patients that you'd seen at least twice through the year. And then we had to meet a certain number of total patients that we saw for the whole year. And they're not, huge numbers, but they were, the thing that, because of the pandemic too, and some of the restrictions in where we could see patients and what we could do. And, we struggled a little bit to get hospital patients, because normally the general surgeons consulted us on lots of patients, but due to COVID and the ICU restrictions, they held back a little bit while I was there, because they didn't, they were just restricting who could come into the ICU. And so they really were not allowing us in if it wasn't something, at least initially, and then the restrictions changed and we were able to get all of our numbers. But yeah, we have the fellowship, the program I did, we had a pediatrician who was ONMM trained. And so we saw tons of babies, tons of little kids. It was great fun. We were in a very DO friendly area. So we had lots of osteopathic specialists who would refer patients to us. So we had obstetrical patients who were referred by several of the osteopathic OBGYNs in the community. There were a lot of orthopedic surgeons in the area who, because we were part of a sports medicine practice as well, they referred complex patients who were just, they'd had one surgery or two surgeries or three surgeries, and they just weren't getting where they needed to go. So they would send those patients to us for assessment and treatment, thinking that maybe we could try something, from a manual medicine perspective versus doing another surgery. We also did a lot of regenerative medicine, ultrasound guided injections. So we more than just osteopathic manipulative medicine, but we were looking at the entire musculoskeletal system and how it interacts with the rest of the body. So a lot of not so much of the viscerosomatic reflex type of work, but we did have patients who came to us with chronic headache and chronic medical problems that we would just work with their body using those osteopathic principles that we're all taught to kind of try to get their autonomic nervous system to calm down, to get their lymphatics moving, to get, just to balance their neuromusculoskeletal system so that they would feel a little bit better and maybe try to get them where they didn't need so many medications and so many other interventions. Is that
John,
kind of?
Yeah, that's perfect. Okay. That's great, John. Thanks. But I'm going to ask just one specific question. So the thing that comes to mind to me on first of all of that sounds awesome. The question that I always have is like pregnant women, like OBs obviously love pregnant women. And I feel like every other doctor, maybe family practice, is used to it. Like as a gastroenterologist, like a pregnant woman comes into your office, you start getting a little nervous. Like you don't want to do anything to hurt the baby, right? So neuromuscular medicine seems perfect, right? But you still don't want to do anything bad to mom or baby. That's a big deal. So like, what are you treating in pregnant women? Are you looking at back pain because they have this big belly with a baby that they're walking around with and their back hurts? Or what are you helping the baby? What are you doing with a pregnant woman?
Yes, it's mostly pain, mostly back pain, neck pain, That's mostly what we saw in the pregnant women. And then we would often try to have them come back shortly after delivery. But, you know how crazy busy it is in a person's life when they just have a new baby. So we had trouble I had trouble getting them to come back right away, because the goal is you treat the little bit of somatic dysfunction that's there that you can find when they're pregnant. And then before the relaxin all, kind of is metabolized away and those joints start to get stiffer again, it's great to bring them back after baby's, been delivered so that you can have them lay on their belly. You don't have to just use seated position and side lying position. You can have them on their belly. You can move them in all the different positions. And then you can really make some nice corrections to some of maybe these chronic aches and pains that they have. But yeah, most of our patients that we saw were back pain patients. Achy back during pregnancy. We found a lot of kind of chronic lower extremity problems that they had that they really didn't even remember that they'd had bad ankle sprains in the past and those kind of things that, were never really treated. They were of that, they're of those sports type people that just rub some dirt on it and get back in there. But nobody ever really took care of those ankle sprains. And so we found a lot of instability. The relaxin just made that instability worse, so when you're walking on a wobbly wheel, just like a grocery cart at the store, that wheel's making all kinds of noise. But these people, they were having minor instability that seemed like it correlated with some of their SI joint and low back pain. And so we were able to kind of talk with them about future strategies, because when they're pregnant, it's not really the time to make major interventions in some of these chronic instability kind of things. But certainly knowing about it and then being able to treat that later is, it's great. It's great information for the woman. And that way they can really take care of themselves as they, as the pregnancy progresses and as they, start to take on their responsibilities as a new mother.
That's awesome. That's cool. Very cool. And again, that you don't want to give NSAIDs, you don't want to do medications that'll hurt the baby in any way. Right. So It seems like an obvious.
Right. And I was very comfortable having, done family medicine and delivered babies and scrubbed on C-sections and all that kind of good stuff. So I was very comfortable. I love taking care of pregnant women. They're awesome. There's something, really fun and enjoyable about that whole experience in a woman's life, and being part of that is just an incredible privilege as a physician to be included in that life experience. And so being able to help them when they have aches or pains. And then I was comfortable. I just, immediately flipped back into my family medicine questions, making sure that all those kind of historical things you can ask about fetal maternal health. And, it was just lots of fun.
So, John, my next question for you, we recently had, and I'm sorry if I misspeak any of this, but we recently had Dr. Hollis talk about cranial manipulation for us. So my question for you, I always think of cranial, and I don't know if this is right or not, but it's sort of like a Jedi master technique. So like visceral manipulation and cranial manipulation were always to me like there's basic OMT and then there's like advanced OMT. Do you see it that way? And was that part of your training? Or do you need to go farther? Yeah.
Oh, no. It was definitely part of our training. Definitely an expectation. And I definitely was not as good at that as I would have liked to have been. So I had the course when I was in school. And, we actually did a 40-hour course spread out over most of our fourth semester. It was an incredible experience learning those things. But I'll be honest, I was not palpatorally gifted, if that's a way we can say it. And so I struggled with it. And I really didn't, I used certain pieces of it. There's like the suboccipital release, the frontal lift. Those were techniques that I felt like I could do, whether I could feel the CRI or not. The cranial rhythmic impulse, which is, kind of the term that some use to describe this ebb and flow, this inherent motion of the brain and spinal cord, and then the membranes that Dr. Hollis was talking about. And that's some people describe it that way. Others have other ways of characterizing that inherent motion in the brain and spinal cord that's palpable. And so, yeah, I was not great at it, but I found that trying, I was able to appreciate those things. And as I got more comfortable as the year went, I still struggled a little bit, but it's sort of, my wife had a statement is you have to, instead of seeing is believing, she said, believing is seeing. So when you prepare yourself and you understand the basic strain patterns, or that seem to be, things that you can feel in different people's heads. When you prepare yourself and you learn those strain patterns and you can start to anticipate, or you start to know where your hands might go. Once I did that, I found that my brain and my hands connected a little bit better, and I started to appreciate those subtle changes. And so that's how I'm teaching. When I'm teaching now is I have this, I let the students know, I said, well, memorize these hand positions. They call it phantom hands, where you have your index finger and your pinky finger, and there's all these motions that you go through to describe or to mimic those classic patterns that Dr. Sutherland described. And once you know what you should be feeling, it's amazing how you start to feel what's present. And so that's it's very doable, I think. And it's actually nowadays, it's a big component of the COMLEX. And so they ask a lot of cranial questions, believe it or not. When we were in school, that was, we learned it at TCOM where I went, but I don't think it was absolutely standard. But nowadays there's a lot of board questions on it. And so I think everybody is at least memorizing the basics so that they can answer the test questions, the written test questions. And we have a few students who just, take to it like fish in water. They just gravitate towards that because they're very intuitive. So it's pretty impressive that it's definitely a teachable skill. But like you say, I kind of think of that too, is that they're sort of Jedi-like, and that this is the temple, and all that good stuff. And so it is, but it's learnable and it's doable. And so while I agree with you, because I always have these people in my mind that are like the gurus of osteopathy, and that they can feel anything. And but I find that most of it is learnable, and it's doable if you try and you think if you think you can, like the little train engine. I think I can. You can do it. It's actually very exciting to see the students who are like, whoa, there is something there. I think I did feel that. And I don't think they're just telling me that because they want me to leave them alone.
John, I'm going to shift gears a little bit. And I want to get into what you're doing now, but I want to start at the beginning. So you told me, I think in an email, you grew up in Kirksville, Missouri. Is that true?
Well, I was born in Kirksville. My dad he finished his undergraduate degree at what was then Northeast Missouri State, now called Truman State, there in Kirksville. My mother, she was a dietitian type position at Northeast Missouri State, and then they got pregnant, and I came right as my dad was starting school, and so he was a first year medical student, and out comes John, and so there I am. So I spent the first 4 years of my life in Kirksville. My dad then graduated and did his rotating internship in Cleveland, Ohio. So I spent a year in Cleveland, and then we moved to a small town in Northwest Ohio where I grew up. And then, the cool story that I like to tell people about the Kirksville thing was that the woman who gave my mother my baby book was in Kirksville. I think her dad was a DO and maybe her husband as well. But she remembers playing horsey on A.T. Still's knee, on the front porch of one of those cabins. So she remembers riding his foot as his leg was a horsey. And so that's just like a crazy connection to the founder that my family has. Then my grandfather graduated from Kirksville in like 42. And then my dad and two of my uncles. So I did my undergraduate degree at the University of Toledo, and I got a BS in pharmacy. Believe that. I went from 100% drugs to no medicine now in my practice. But I had a phenomenal experience in Toledo. I had many phenomenally great mentors at the University of Toledo. I can't recommend that university enough to people who go there because it was a wonderful experience.
So,
and
John,
then,
I just want to stop you 1 sec. So you're a pharmacist.
Yes.
Is that right? So you're a pharmacist who does manipulative therapy. That's cool. Sorry to interrupt, but that's very cool.
No, it's great fun. I mean, there's so many cool things that we learned in pharmacy school that are, that pharmacology is so fast in med school that, I learned in great detail, and it was just loads of fun. But I'm telling you that pharmacology has just exploded since then. And things that, you remember when we used to dump everything from the liver was, it's cytochrome P450s. And now they actually know which cytochrome P450 they use. And you're like, oh boy, am I glad I didn't have to know that? Because it used to be, you could just get away with that one answer. Oh, it's a cytochrome P450.
So John, now when you went to pharmacy school, were you thinking you're going to be a pharmacist? Like, when did you decide you want to go to medical school, and when did you decide you're going to be a DO? I went to pharmacy school because I didn't know what I wanted to be when I grew up. I was comfortable in the medical space since my dad and grandfather and several uncles were medical, and so I was very comfortable with the language. I liked science. I did okay in high school. I went to high school to play football. That's what I did. And all that kind of stuff that goes along with that. So when and then one of my buddies says, I'm going to go to pharmacy school. I'm like, oh, that sounds cool. So I shadowed for a day with the neighborhood pharmacist. And I said, ooh, I could do this. This looks like fun. And so it was my freshman year in the dormitory, and my residence hall advisor was pre-med, and his then girlfriend, now wife, was a pharmacy school student. And so they were several years ahead of me, obviously. And so I had a project. I don't know what it was, but I know it was. I had elevated bilirubin as a baby, and they had to do a transfusion because they didn't have Billy lights yet at that hospital in Kirksville. So I had to be transfused because my bilirubin was too high. And so I said, I'm going to write a paper on that process. And so I was really excited about that. And I was really excited about, chemistry and physics, everything that I was taking. So I would just like explode with conversation because I knew my RA was a science guy, pre-med. And he says to me one day, he says, John, you're way more excited about this material than anybody that's over there that my wife runs around with or girlfriend at the time runs around with in the pharmacy school. I think you really should go to med school. And I'm like, no way, I'm not going to med school, because my dad was in private practice.
he never came home. He worked, 2 extra ER jobs to make the family medicine clinic, or office profitable. And so that we had food on the table. And, we had to go in to wake him up to say goodnight, because he was crashed and he left early in the morning. He was phone calls all the time. And I'm like, I do not want that life. Well, as I got through pharmacy school, I realized when I'm working in a hospital pharmacy and I'm looking at all these residents that are running around, and I'm like, I know as much as these guys do. There is not, I could do that. And so I kind of falsely believed that I only needed to learn, just a little bit. But in fact, what I actually knew at that time was just a little bit. So, but then as far as DO school, I'm one of those weird kids. I grew up with all osteopathic physicians in my family. I knew that MDs existed because I saw them on TV and they were in the community a little bit. But I mean, I grew up with the artery is supreme as one of my mantras growing up, and that reestablishing good blood flow solves lots of problems, and so there was never a thought to throw my hat in the ring to go to an MD school. I just didn't feel like it was, I felt like it was too limited. In my training, I would be, I wouldn't know the important things about osteopathic manipulative medicine that if I hadn't, if I would have gone to MD school, I would have had to go seek those afterwards. And I just felt like, I would go to DO school. So I applied to the family school out in Kirksville and at TCOM, and I was fortunate to get accepted there. And so I had some options, and my wife was like, hey, I'm a respiratory therapist and I like to work in the ICU at this point in my life. And the ICU in Kirksville is pretty small. So you think we can maybe go to Texas to Fort Worth? It's a bigger city. There's several options for me to work and feel fulfilled. I said, absolutely, let's go. So we loaded up the truck literally and headed to Fort Worth, and just had a phenomenal experience. Like everybody else, fall semester of your first year is a kick in the teeth. There's no preparing for it. No matter how prepared you think you are, you're going to get smacked down. And I made it through that, and my wife had a good job, so she was making friends and fulfilled. There was a nice spouses group. So she was part of that and got to know a lot of the other spouses. And then those tended to be who we hung out with and friends at school. And it was awesome. I mean, it was as good a family experience as you can have going to a medical school. So that's how we got here. It was my RA who said, John, you really like that material. And then, kind of that's put the seed in my head. And then I realized I think I could do that.
So then, John, you told me you took a military scholarship. Is that how you helped finance?
I did. Yeah, we financed medical school through the Navy Health Profession Scholarship Program. It was, I applied for that in the Air Force. My dad served in the Air Force, so I was kind of like, man, it'd be fun to be in the Air Force. And just the way it works when you meet the recruiters, meet the people, it just felt like a better fit to join the Navy. And so and the Navy offered me the scholarship, thankfully. The Air Force had me on a wait list. And I said, hey, look, a bird in the hand is worth 2 in the bush. So I'm going Navy. And I got the initial training. We had lots of fun. I did my internship. I got selected into the internship in the Navy. And it was a great family medicine experience. There were, there were probably a third of the faculty were DOs, and about at least a third, if not a half of the residents were DOs. So there were plenty of us that, we were looked at as doctors. We weren't looked at as, oh, you're the DOs, you're the MDs. The only thing they sort of had an unwritten rule is that if you're a DO, we need you to do OMT. Mm-hmm. And so we had a little OMT clinic, and we could see OMT consults even as interns. We would get OMT consults in our regular clinic space. So and then my patients, I treated a lot with OMT, and we had a great time as interns doing OMT. I shared an office with two other people. Funny, both of them are MDs, and they were both trained in Philly at two different schools. But the one guy was married, and his wife came in, and she'd just seen one of our faculty members, because we didn't see residents' spouses, and she was having some vertigo. And turns out she's a physical therapist. I didn't realize it at the time, but she'd gotten a prescription for Anavert. And I said, well, I could try giving you a treatment. And so I didn't know that she kind of knew what that was, being a therapist. And so she said, okay, let's try it. So I treated her, just used high velocity manipulation, in a general fashion. And then I did some suboccipital release, and she gets off the table, and she's like, no, didn't help. I'm like, okay, well, go get your prescription for Anavert. And, if you want, we can try it again. And so about an hour later, I get my office mate, comes in and says, hey, John, my wife's vertigo went away by the time she got home. I'm like, cool. I said, did she take any medicine? No, she didn't have to take any medicine. I'm like, sweet, win one for the Gipper, and so I was like, cool. I've had lots of success with vertigo using that same basic protocol since then. It's a little more sophisticated as I've gotten older, but basically the same thing.
So, John, after you finished the military, did you practice? You said that there was a big gap before, obviously, you went back to residency for OMT or neuromuscular medicine. What did you do in the interim?
Well, I served for 20 years in the Navy.
Wow.
And so I did my full enlistment so that I could retire. But I did my internship, and then I went out and did undersea medicine. I was selected into the undersea medicine program. So I went to training to learn the environmental things on a submarine, because, it's an enclosed environment. So they have to make their own air. They have to scrub out the CO2. They're living right next to a nuclear reactor.
Wow.
And so there's a lot of medical implications that go into that. And so I learned those things. And then that's also part of the diving Navy. So we went down and we learned to be certified Navy divers, meaning the hard hat type of divers, with surface supply. So I learned how to do that. And then I went back to school a little bit more and learned deeper diving with mixed gas. So using helium instead of carbon dioxide in the air mix so that you can go deeper. And then I was stationed in Hawaii at a diving and salvage command. And so we got to do some pretty amazing things there. I was involved in some pretty big international things. We unfortunately, there was an accident. It's all public record. And it was where the USS Greenville surfaced in an emergency blow practice, and they hit a Japanese fishing vessel and it sunk. So we were involved in the recovery of the remains of those people that died in the accident on the Japanese fishing vessel. And so we did the recovery on that. So it was an amazing experience out of a horrible tragedy, for learning Japanese culture, learning, how to dive in enclosed spaces, how you would execute this from a engineering perspective. So lots of phenomenally amazing learning that went on there, like I said. And how do we manage this horrific grief that these families had, associated with this terrible accident? So it was, just an amazing life experience to be part of. I went back, I did family medicine. I was stationed in Guam, where we did full scope family medicine, ICU work, really sick people that we took care of in the ICU and those kind of things as a family doctor. And so just an amazing medical experience, a great family experience, because we were so far away that all the holidays had to be with our friends who became our family. I was really fortunate. There were 5 of us from my residency program that all went to Guam. So we basically moved our play group to Guam for the kids. And so it was awesome. It was an amazing experience. And we made so many friends there that are now lifelong friends. It turns out some of them grew up like 30 minutes from where I grew up. So our parents had actually known each other long before we did, but we got to know each other in Guam, of all places, from Northwest Ohio. I went back, I did my sports fellowship at the Naval Hospital at Camp Pendleton. Wonderful experience there. And then I was stationed in Okinawa, Japan for 3 years as the sports medicine doctor for the Marine Corps out there. I had 3 offices. I had 3 doctors that worked for me, and we did nothing but musculoskeletal medicine. And we took care of Marines, sailors, soldiers, airmen, a few family members who had, musculoskeletal problems that weren't necessarily being managed by their primary care. So we took them in, and that they couldn't get into ortho, or they, weren't operative. So some rehab, I learned medical acupuncture at that time. I used a ton of OMT. I worked with the chiropractor that we had that was stationed out there. And so we would pass patients back and forth. So it was really a sort of a musculoskeletal practice utopia, honestly. And I had a little bit of an administrative job. I was the deputy group surgeon. So when my boss was gone, I went to the meeting with the general, and I represented all of the medical for that segment of the Marine Corps that was there. So I had this great clinical job, administrative, and my boss was exceptionally good. He's still one of my mentors now. And then I went from Okinawa, and I went to the United States Naval Academy, to the clinic that was associated with the Naval Academy. And as a sports doctor, I was billeted in as the team physician for the football team and for the wrestling team. And so I rolled into that. I worked with an orthopedist, and the two of us covered the football team. And then we had some outside orthopedists that helped too. We had a team chiro. So he would treat, some patients I would treat. I did tons of OMT on those guys. My clinic, again, it was a primary care sports clinic. I took care of mostly the midshipmen, but again, some of the family members and things would come down from the clinic. We would see a specialty consults for OMT and acupuncture for pain. Again, it was mostly pain. And then I shifted from that. I moved over to DC, to the Navy's Wounded Warrior Command, where it was mostly an administrative job, where I was screening people and making, decisions whether or not they met the criteria of being a wounded warrior. But as part of that program, once they were in, we had an adaptive athletics program, which is very much like the Paralympics. And then we had both a United States inter-service games called the Warrior Games, where all the services competed against each other. So the Marine Corps, the Air Force, the Army, the Navy, and Special Operations, because Special Operations, under the federal funding acts, they have the same ability to equip and train that the Navy or the Army or the Air Force does. So they're kind of a fifth service that people don't really realize that. But it's all federal law, the way that the federal money flows for the military. And so they would get together and they would play wheelchair basketball, seated volleyball, swimming, running, all these things. And so I was the team doctor for this thing. And then there was this international that Prince Harry put together called the Invictus Games. So I got to go to the inaugural Invictus Games, and I was the lead team doctor for the US team. And so I covered Paralympic sports in London at the Olympic Park that they had in London. It was just an amazing experience. And then I finished my career in the Navy down here in Pensacola, and I retired out of the sports clinic that was associated with the training pipeline for the young sailors who were learning how to fix airplanes, load bombs on airplanes, how to do, all the electronic things for airplanes. So it was basically everything aviation minus the pilots. I saw a few pilots, but not very many, but it was mostly just everybody who supported the aviation Navy. And that was my patient population. So I saw them, retired from the Navy, joined the faculty at the Alabama College of Osteopathic Medicine.
I'm sorry to interrupt you, but
I know I can go forever.
Yeah, no, you're doing great. But I just want to comment, we interview DOs to listen to their journey. And up until this point, I would say that your life is like 7 journeys. Like if we took 7 people's episodes, and I think the only exception, the only person that's giving you a run for your money is Dr. Anderson. I don't know if you know him.
Bill? Yeah, I know.
Bill Anderson may give you a run for your money, but it's tight. It's a tight race. You did a lot.
Yeah, well, Bill has got, I mean, his story blows anything that I could do in my life away. I mean, what a man. I mean, what a giant.
Spectacular. But you're on his tails. You're on his tails. So, okay. So,
I appreciate that.
Yeah. Amazing. So you retire now from the Navy, and now you start a new journey. Like, you've already done 7 journeys, and now you're going on to your 8th journey. So tell us.
Right. No, I was coming out of the Navy and I wasn't sure what I was going to do. As a sports doctor, I was trained just before ultrasound guided injections were a big thing. So I didn't have the ultrasound guided injection skill set, which is what it seemed like most of the sports doctors needed to have in order to get a job working in an orthopedics office and just doing MSK. And I'd only done MSK, musculoskeletal medicine, for the last 12 years. So I was really rusty at regular family medicine. So I was feeling like, what do I do? I was very anxious about that. And so I went to the AOA meeting, and, I'm wandering around looking at all the trinkets and junk that all the schools have. And there's this big, tall guy standing there at the Alabama College of Osteopathic Medicine's booth. And I grab like one of those leather coasters, right? I'm like, oh, a leather coaster. I like that. That's kind of nice. I'm just going to grab one of those. So he strikes up a conversation. Well, it turns out it's the dean. And so we were talking. I said, oh, well, I live in Pensacola. I'd love to come up for a visit. He's like, yeah, give me a call. Here's my executive assistant's phone number. Just call her. She, it's Dawn, and we'll have you come up. We'll, maybe take you out for lunch or something like that. That sounds great. I'm all for free lunches, and so I called and I set up a time to visit on Veterans Day, because I had the day off. I said, well, I'm going to drive up and go up and say hi. And so they called me back about 10 minutes later and said, hey, John, the dean and I are sitting here talking, and would you be willing to come and give a talk over lunch? And I'm like, yeah, sure. What do you want me to talk about? Oh, I'll just talk about your practice. That would be interesting, I think, to everybody. Okay, I could do that. And maybe stay a little bit, maybe come a little bit earlier. Maybe why don't you just come the night before and we'll go out to dinner and do all that stuff? I'm like, yeah, sure. That sounds great. I'd love to. That sounds like fun. So I get home and I tell my wife this, and she's like, John, that's an interview. That's an academic interview, because she had worked at the Naval Academy. And so she had set up these interviews for faculty coming in. And it was always, you come in the night before, you go to dinner with the dean, and then the next day you go through a series of things, and then you give a talk, and then, they sit down and go through HR stuff, and then you go away. And a few days later, they call you and say, yeah, come on, we'd love to have you on faculty. Or, hey, thanks for coming, but yeah, we're going to move in a different direction. And so I interviewed. I didn't even leave the building, and they said, well, we start salary at this, and when do you want to start, basically? And I'm like, whoa, this was not even what I expected. I said, I can't make the decision. There's still one more promotion board. I might not get out of the Navy. So I worked on that instead. And then my wife said, well, let's drive up. So we drove up to Dothan here on a Sunday afternoon. She said, I just want to see the community. So we drove up, we went to a little Greasy Spoon for, lunch, and had this great Southern meal. And she's like, this isn't too bad. Maybe this could work. Let's do a second interview. I want to come. I want to interview him. Like, okay, that sounds great. So we drove up and we went through and kind of did not quite as long of an interview, but we interviewed a little bit. And then they, again, proposed a salary, and I looked at her, she looked at me, and she said, yeah, that sounds fine. And I said, okay, that sounds great. And they said, we want you to teach in the osteopathic manipulative medicine department. And, then of course, sports medicine and family medicine, you can help out with those things too, but we really need you in the OMT teaching department. So I said, okay, that sounds great. I really love OMT, and I think it's been an incredibly important part of my practice so far. And I said, great. So we got started. I came up, but I quickly realized that my knowledge was not where I needed it to be. I didn't have the depth of knowledge. I had the same training that all the students were getting. I didn't have more training in different things. So I said, I've been wanting to do this osteopathic neuromuscular medicine training for a long time. Maybe I should do that. And so we finally decided after I was nearly done with the second year of being on faculty, and I really came home and I was like, hey, to my wife, I said, hey, I'd really like to do this. And she's like, hey, we're in a good spot. Our kids are at the right spot. Financially, we're in the right spot. Do it. If this is what you want to do the year of training. So I sought a couple of opportunities, and then COVID hit. It took one opportunity off the table for me, and then another opportunity opened, and I went up to VCOM in Virginia at Blacksburg, and I did the osteopathic neuromuscular medicine training there. Phenomenal year of training. That's my story. That's how I got where I'm at.
That's amazing. And I'll tell you, we got your name obviously from Amir, who's one of our producers, and he was like, John is amazing. You need to interview him. And, he's an ER, he wants to be an ER doc. So I think the fact that he's so taken by you and influenced by you as a neuromuscular medicine physician is awesome.
Yeah, no, and Amir and his wife, they're some of the just great young people. They're going to be phenomenal doctors as they graduate this year. They're just going to do great things. They're impressive individuals. They're great. I can't say enough nice things about them. I enjoyed them immensely when they were students and we were teaching and chatting, and I like them even more now as young doctors, young colleagues that, we can talk about other things than just that teacher-student relationship that, that it's, hopefully it continues to blossom into a friendship.
John, can you tell me, we have some pre-medical, we have a lot of pre-medical students that are listening. So, I always wonder, when osteopathic medicine was a little bit younger, maybe there were 5 schools, 7 schools, 10 schools. I think when you and I applied probably around the same time, let's say there were 17 or 20 schools. Yeah. And now they say there's I was listening to one of our old podcasts, and, one of the people we were interviewing was saying that there are 60 campuses currently.
Right.
So if a student, and I want you to brag a little bit if you could. So
sure.
If a student was looking to go to osteopathic school, listening to our podcast, this is awesome. This is what I want to do. What are some things about your school specifically? Can you tell us about your school? Can you tell us about the city? Can you
Absolutely.
Tell us the name of the school? I don't think we named the school.
It's the Alabama College of Osteopathic Medicine.
So why would they go there? Why would a student go to Alabama? Or why should they think about it?
It's a great school. It's perfectly poised in its young life. It started early, or just, in 2013, I think is when we started. I'm terrible. I'm not remembering the history very well, but it's a great size. There's a great faculty that's very much a family feel with the faculty. And I think, by and large, the faculty really love teaching. And, it's like a lot of the smaller DO schools where the focus is on teaching. We've got people who are passionate about research, but they don't have to do research in order to stay employed. And so they focus on teaching, and they use the research to augment their love of teaching. And so it's really a nice place. We've got nice facilities. It's a new building. It's not musty and old like some places. We're in a great location from a family perspective. The community is wonderful. It's not a huge city, but it's not a small town either. There's plenty of things to do. There's plenty of restaurants, plenty of activities. There's not a major university in town, but there's plenty of opportunities for higher education. And then we're very close to the beach. we're about an hour and a half from Panama City. So straight south. It's an easy drive. It's a wonderful day trip to go down to the beach. We're 2.5 hours from Pensacola, Florida, which is, where there, again, more beach. We're an hour and a half from Tallahassee. We're 2 hours from Atlanta. We're an hour and a half from Montgomery, about 3.5, 4 to get up to Birmingham. Mobile's just a hair past Pensacola, so it's about 3 hours. So we're really nice, and then New Orleans about 3 hours beyond that. So we're about 6 hours from New Orleans if you like the Mardi Gras. And Mardi Gras runs pretty much all the way, with the parades and everything, pretty much run all the way to here. So there's plenty of Mardi Gras stuff if you really like Mardi Gras. And just back to the school itself. There's a dedicated group of professionals that do the day-to-day running of the school. The faculty are great. I think we've got a robust clinical network of places to go. So you don't have to go out and arrange for your third year core rotations. We do that for you. Pretty much we've got a few sites in Mississippi. Most everything is in Alabama, and then we have some sites down in Florida, which is nice because we have quite a few students from here in Alabama, but then we've got a big group from Florida as well because we're neighbors, and we're in the southeast corner of Alabama, so we're like if you go 15 minutes east, you're in Georgia, and 15 minutes south, you're in Florida. So we're really close to this tri-state area, if you will. It's a very nice community. I stay up here during the week. We retired out of Pensacola, so I drive back to Pensacola on the weekends. My wife has a business and she's working down there, so it's not as easy for her to just pick up and move up here. But I think there's plenty of good things at our school. We have pretty great OMT instructors. Besides me, I'm not saying that's me, but we've got a couple other guys that are really good, and we're making, I think, very positive moves to make the school better. There doesn't seem to be much backsliding. Of late, we've really added training and things for the third year core preceptors, so they're even more understanding, and we're going to do a little more teaching of basic OMT so that students have more support from our network. That's frankly a lot of allopathic physicians, a lot of MDs are in our group. They're passionate about teaching students for the most part. There's always some that said yes, I want to because that's the right thing to do, but they're still focusing on their practice. But they're great environments for the students to see patients and learn from these experienced physicians. But they don't understand osteopathic manipulation. So we're working to try to teach them and to expose them to the basics so that students can feel comfortable in doing more of that in the clinics. And so I think that's a unique thing here is that we're working to grow our faculty knowledge of manipulative medicine and osteopathic principles and practice.
John, I think the school sounds awesome. If I was applying, I would definitely throw my hat in the ring. It sounds great. Alabama sounds great. You're obviously awesome. I'll just say we just had a recruiting session for people to help with our podcast. And the response from your school supporting us, it has been tremendous. And great. Alabama is now the number one supporting school, I think, for our podcast. So you're number one in my book.
Cool.
All right. Awesome. Thank you for spending the time with us tonight.
Absolutely.
And I have one closing question. So our closing question is always the same. Some people think it's a little tough. I think it's a good question. So the question is, give us one piece of advice that you were given from someone else, and that could be from your dad, from the woman that gave you your baby book that hung out with AT Still, from somebody from the military, somebody from your residency, just, at least one piece of advice that really you feel is profound and that you think would have value if you shared it with our listeners. Right.
No, that's perfect. Yeah, I hadn't really thought about it, even though I listened to a bunch of your podcasts and I just totally skimmed over this one. I think the most important piece of advice I got was not really advice, but it was an expectation. It was do the right thing. And so, as an intern, I would say, well, what do you mean by do the right thing? And the answer that I got was, John, if we didn't think you knew what to do, we would not have brought you here as a resident. So that's not really an answer you want. So the answer that I've come up with over time is that doing the right thing means that you take care of your patients. If they call at 5:05 on a Friday night and you're supposed to be going home at 5:00, you're still there, you get the message, you do the right thing. You take care of that person. That doesn't necessarily mean that you have to do it yourself, but you have to at least acknowledge their concern and give them advice to go to where they need to go. Now, if you're the one who did the procedure and they're having a problem, then your right thing to do is meet them in the emergency department and take care of it. And your pregnant patient is, breaking down because their husband or baby's father, whatever, and you need to spend an extra 15 minutes. Somebody just lost their baby. You get the phone call from radiology that says, hey, we have no fetal movement. And you're their primary doctor and you're going to take them up to labor and delivery and you're going to be with them until they deliver. And, that they're safe to be discharged home. And you're going to be there with them through that, that horrific life experience they're having. And so doing the right thing, I think that is something that we've maybe forgotten in our discussions with the young physicians about the things that they need to do to be a great physician is to do the right thing. And, because we all get so wrapped around the axle about insurance companies and now we're all employees and those kind of things. And so we forget that, yeah, those are things that we have to deal with. But at the end of the day, these patients have given us this privilege of being their doctor and, we owe them to do the right thing. So that's my piece of advice. That's what I try to tell the students when they, want that kind of a question. I said, just do the right thing.
I think that's awesome advice, John. John, thank you again so much for your time tonight. I really appreciate it. And I'm sure our listeners do as well.
Thank you very much. This has been great fun.
All right, John. Have a great night.
Thank you, you too.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tianyu Shea. Thank you guys so much for listening to Do or Do Not.